Everyone, thank you so much for logging in to our Business Health Connect during lunchtime today with Dr. Donnie Aga and Dr. Melanie Mouzoon from Kelsey-Seybold. I'm Lane Galata, one of the marketing team members here at Kelsey. Before we go ahead and get started, we'll go over a few housekeeping rules, although by this point in time, I think all of you are familiar with Zoom and the features. We'll just do a quick rundown while we're waiting for everyone else to join us. At the bottom of your screen, you have a Q&A button and a chat feature button, and we definitely encourage you to use it during our presentation to ask any questions that you have for Dr. Aga and Dr. Mouzoon during our time with them today. And we are on a timeline. They do have to get back to seeing patients this afternoon and have other meetings on their calendar. So if we don't get to all of your questions during the time we have with them today, we will have someone from our Kelsey Care team follow up with you. So please know we'll do our best to make sure we get all your questions answered. But if they don't, we have a plan of action for follow-up for you. So we'll go ahead and I think jump right in. We'll do a quick introduction. Dr. Aga, would you like to tell us a little bit about your background and your time here at Kelsey?
Hi, I'm Donnie Aga, and I'm an internal medicine physician, and I've been with Kelsey for 24 years now, and I work at the main campus. And I have been the medical director of healthcare innovation. And then most recently, I've been in charge of our COVID team and how we responded to the pandemic. So virtual health and telemedicine is my area of expertise. And then also pretty much all things COVID.
Wonderful. Dr. Mouzoon, I know you have a hand in managing COVID at Kelsey as well. Would you like to tell us about your background and your role with managing the COVID pandemic?
Yes, I've been with Kelsey-Seybold since 1985, and I really work primarily on immunizations, which allows me the opportunity to go to the national immunization conferences when they're national conferences, and those focus a lot on pandemic influenza. So my background is really on pandemics and influenza vaccine and also on other vaccines. So I manage our policies at Kelsey-Seybold to encourage people to get vaccinated and to make sure that we're doing everything in the most up-to-date way.
Wonderful. We're going to go ahead and jump right in. So again, your cameras and microphones are muted just so we don't have any interruptions and we can get through all of the important information Doctors Aga and Mouzoon have for you today. We're going to go ahead and share a presentation with you. But again, please feel free to ask questions. We'll probably hold the questions till the end, but we'll do our best to get through to all of them for you. So we'll go ahead and jump right in.
So yeah, there we go. So I like to give people just a general idea of what a vaccine is to begin with. You all can recognize a white coat may indicate that a person is a doctor. And just like you can recognize people by their uniforms, your body has the capacity to recognize non-human proteins. And it's really a remarkable capacity. We can recognize thousands of different viruses and germs. And what a vaccine is it's a copycat of a pathogenic germ or a copycat of a dangerous germ. By that, I mean that most vaccines are a copy of the protein coat that this virus or bacteria wears. And once our body can recognize that protein coat, then when you encounter the real illness, that virus or bacteria may enter your body, but it can't survive for long because your immune system recognizes it and clears it from your system. So, you know, the older vaccines sometimes were a whole killed virus or a whole killed bacteria, but these coronavirus vaccines are only a few of the proteins on the surface of the virus. And by developing immunity or recognition of those in our body, we then can safely be exposed to corona without getting sick. Next slide. So some people have concerns about messenger RNA vaccines, and really messenger RNA is a nucleotide-based, I'm trying to not say protein because it isn't a protein, but it's genetic material that is sort of a stencil system for our bodies. So your DNA, when it needs to make a protein, when your body needs more hemoglobin or it needs more keratin or some protein that is part of you, your body produces messenger RNA and stencils a bit, taking a stencil from a bit of your DNA. And that messenger RNA is then put into the cell outside the nucleus, and that's where it is producing protein in a cellular organelle. And so basically what happens with messenger RNA is it's a very short-lived molecule. That's because you don't want to make way too much hemoglobin or way too much keratin or any of these other proteins. So this molecule actually is designed to disappear pretty quickly. And that's one of the reasons these vaccines need specific storage requirements and are not supposed to be shaken and all kinds of things like that, because this molecule doesn't live very well on its own. It falls apart. Because these messenger RNAs are coding for the spike protein, basically when you get a shot of a messenger RNA vaccine, that vaccine basically is just just giving your cells the opportunity to make a protein they haven't made before. And by making that protein and then expressing it on the surface of the cell, your body then recognizes, well, there's something weird about that cell. That's not a human protein, and then develops immunity to it. Next slide. So a lot of questions have arisen in the public about, these vaccines may not be safe because they were made too fast, and, concerns about how did this happen so fast? Well, really, all of the steps of normal vaccine production have been taken. They've just been accelerated because usually, a first step will be taken and people will publish papers and then they'll be peer reviewed, and it takes a while to kind of move forward with the process because there's no urgency to it. And usually vaccine producers are, using their own funds to produce vaccines. And so they have other projects that they're doing. And so they may not put much funding behind vaccines. Because the pandemic is not only killing people, but ruining our whole economy, the government provided those funds that were necessary so that the companies could develop the vaccines without delay. And the steps of production really have not been skipped, but kind of like instead of doing a relay race, all of these steps were done with much more overlap and not waiting for each step to be completed before the next step was done. The safety and efficacy studies could be done also pretty quickly because there were so many people getting sick. So, you take a large population of people, you give them the vaccine, and, you don't even have to intentionally expose them when there's so much COVID in the community. You can pretty quickly tell whether the people who are vaccinated get sick less often than the people who were not vaccinated or the control group. So basically, we need to understand that the best way to find out if something is safe is to test it in large numbers of people and to follow the people who get the vaccine. So there's a program called V-Safe that every vaccine recipient can enroll in to let the government or let the CDC know if they're having any side effects that are unusual from the vaccine. So not only did we test these vaccines in large populations, but much larger populations are being followed for vaccine outcomes that might be related, or for outcomes that might be related to the vaccine. And it's important to recognize that bad things happen to people all the time who've not been vaccinated, and those things will still happen to people who have been vaccinated. Cancer diagnoses or blood clots, for example, is kind of the question of the week. And so really the larger the group of people you're following, the better you can tell if there's any relationship. So one of the non-messenger RNA vaccines that's in the news this week, the AstraZeneca vaccine, some of that vaccination has been halted in certain countries in Europe, much to the dismay of many infectious disease doctors, because there were some people who reported blood clots, but not above the population at large's rate of developing blood clots. And COVID itself can cause blood clots. So it's kind of remarkable to me that they decided to stop vaccinating people with that vaccine temporarily because they really don't have great evidence of causality. So basically, when there are individual stories about bad outcomes, they should be reported, they should be checked out, but you shouldn't believe that they are necessarily factual as a cause of that the vaccines caused that reaction until it's really thoroughly investigated. Next slide. So this VSafe program, you can look it up on the internet. It basically is collecting the data in another data set called VAERS, which is the Vaccine Safety Data Link. It's been used for years to monitor people's reactions to vaccines, and it's all voluntary reporting. And I'll just go on to the next thing. There's the Vaccine Safety Data Link is also a monitoring system where over 300,000 people in the US are followed for any potential adverse outcomes after vaccines. So who shouldn't get the vaccine? It's really very limited. If someone has a severe allergy to a component of the vaccine, or they had a bad reaction to the first dose that was allergic in nature, then they should not get the second dose, or they shouldn't be vaccinated if they know they're allergic to one of the components of the vaccine. And there are only two components that are really of concern, the polysorbate and the polyethylene glycol. And those are parts of many other medications, including over-the-counter laxatives, for example. And sometimes people may not know that they have an allergy to those components. So we are monitoring people after they get the shot for 15 to 30 minutes to make sure they don't have an allergic reaction to the vaccine. And then those younger than 16 are not being vaccinated yet unless they're part of a clinical trial. And there are clinical trials now available for children to enroll in. Next slide. The side effects, that your employees and you may get after getting this vaccine really are annoying but not severe. So it's common to have fatigue or headache, to have some muscle aches. It's very common to have soreness at the site of the injection and some redness. Some people, particularly after the second dose, will be a little more sick than after the first dose. And there have been people who get, rashes from the shot area, the whole length of their upper arm, and some of those can last 2 weeks. What these reactions are signs that your immune system is taking note of that foreign protein and developing immunity. And the skin reaction can be kind of prominent simply because the skin is full of the kinds of cells that develop immunity in our systems. And some people will even get swollen lymph nodes under their arms. So that's all expected and not of concern. Next slide. So it's being shown very clearly that these are very, very effective vaccines. So in the trial that they were like 95% effective for the mRNA vaccines. And unfortunately, I don't have an update in here about the Janssen vaccine very much, but what's interesting is that both the mRNA vaccines and the Janssen vaccine, which is a viral vector vaccine, which is a little different, but another way of presenting this foreign protein to your immune system. They are all 100% effective against dying from COVID or having a severe hospitalization. So effectiveness doesn't occur as soon as you get the shot. It takes your immune system a little while to be protected, but basically 2 weeks after your second dose of the mRNA vaccines, and somewhere between 2 and 6 weeks after your first and only dose of the Janssen vaccine, you are now at full protection from hospitalization and death. So it doesn't protect you if you get exposed the day you got the shot, because it hasn't had time to teach your immune system the playbook. So efficacy is so good that the CDC now says that if people are 2 weeks out from dose 2, that they don't need to quarantine if they're exposed. So that has a lot of ramifications for your employees and getting back to work and obviously will help you keep more people in the office and busy with your businesses. Next slide. So the mutation of the coronavirus is something that's being watched with a great deal of concern, actually, because we know from flu viruses that they mutate frequently and they can escape our vaccine protection. And the coronavirus so far has not escaped from vaccine protection for the more serious forms of illness. But the milder forms of illness are showing a little less ability, it's showing a little less ability to protect against milder forms of illness, particularly with the South African and Brazilian variants. And these variants are both more contagious and more serious when you catch it, or more virulent. And so it's important to recognize that the newer vaccine that was released, the Janssen vaccine, while it doesn't look good in numbers compared to the first two, the Pfizer and Moderna vaccine, that is because their trials, the Janssen trials, were done at a time and in locations where there were more variants spreading. And if you repeated the studies of the Moderna vaccine and the Pfizer vaccine in South Africa and Brazil, where there are now circulating variants, you would probably find pretty similar numbers. And the way the Janssen vaccine works is this viral vector actually exposes you to the spike protein for a longer period of time. And so it starts building up immunity slowly and then develops it as late as 28 days later, you're still improving your immunity. So it works a little bit differently because unlike the mRNA, it doesn't disappear quite as quickly. And so you develop just as strong a protection, but over that same period of time. So basically, someone who has to get 2 doses of a Pfizer vaccine 21 days apart and then wait 2 more weeks is at the 5-week mark, and the Janssen vaccine reaches full effectiveness around 4 to 6 weeks. So they're really equally effective, and you should take the first vaccine, and you should encourage your employees to take the first vaccine that is offered to you. Next slide. So the big question is, when can we lose these masks? So those who've been vaccinated, really, when you're out in public, please continue to wear your mask, social distance, and encourage others to continue to wear the mask. I know we have some some proclamations about, going back to 100% capacity in bars, for example. And we need to recognize that we have a lot of unvaccinated people in the community, and we need to maintain this social acceptance of everyone wearing masks, because the masks have been very effective at reducing illness and death. You are safe to enlarge your home bubble to others who are vaccinated and socialize in your home with other unvaccinated people. Once we have, with other vaccinated people, and you're allowed to now socialize if you're fully vaccinated, meaning 2 weeks after your second dose or 2 weeks after your Janssen dose, you're also allowed to socialize with one other vaccinated household at a time. And so that has implications for workplaces as well, once we get larger numbers of people vaccinated. So employees who are vaccinated would be able to work together unmasked in an indoor setting, for example. So the more people we get vaccinated, the sooner we'll get back to normal workplaces as well. Next. So we are doing additional studies to better understand whether people can be carriers of the disease after being vaccinated, meaning that they might have asymptomatic infection and spread it. But it looks like that is not going to be the case, that people who are vaccinated are not likely to be spreaders, but more to come on that. And the estimate is that 7 or 8 out of every 10 people will need to be vaccinated and immune before we can really be normal. And so that's about 250 million people that need to be immune either from illness or from vaccination. And, clearly we don't want to rely on infections alone, because that would kill a lot of people unnecessarily. And so really encouraging vaccination is the way to go. Next slide. And travel is the other big question. So travel increases the spread of variants around the globe that might not be prevented with vaccinations in the future, particularly as the variants themselves change and become more adept at infecting us. So vaccinated travelers, of course, are safer for themselves and for others, but could still catch a variant and conceivably could still have an asymptomatic infection and spread it. So again, continue to mask and social distance, avoid travel when possible. If you're going to travel, get vaccinated first if possible, and really think twice about travel to South Africa, Brazil, and the United Kingdom because of those variants. And when can you get the vaccine is another big question. So the state is in charge of vaccine rollout, and they have really moved us all into this phase 1C and even more because they've lowered the age to age 50 in the last week. And so unfortunately, that means that the vaccine timeline here, you see the curve, the overall curve is how much vaccine we expect to be available. And this was put out in December of 2020. And we are starting to have that upsurge in vaccine supply because of the Janssen vaccine availability. But really, we still don't have enough vaccine for everybody who's in 1A and 1B, and we've moved well beyond that. So, we at Kelsey-Seybold vaccinate with basically all the vaccine we get. We're working on our highest risk populations and moving through those as fast as we can with what we receive. And the hub vaccination centers are available to others who are in these risk groups, age 50 and up, and those with high risk conditions. So this is Dr. August's turn, I guess.
Okay, thank you, Melanie, for that very thorough presentation on vaccines. And just as Melanie suggested, when it's your turn to get a vaccine, definitely take your turn. And Texas has moved to these vaccination hubs where there's large number of patients able to get vaccinated. And so when it's your turn, please, the risk is very low, the benefit's very high, and it's the closer we can get to getting back to as normal a life as possible, and hopefully at some point, life without mask, et cetera. Just some update on our latest COVID data. And the goal of my presentation is I think most of us are aware or have heard presentations on COVID, watch the news about COVID. And so just kind of some updates on where we are on COVID today, what's new, things that maybe you haven't heard about and that I wanted to cover. So now we're almost 30 million cases in the US, over 500,000 deaths. And in the state of Texas, now approaching 3 million cases and 45,000 deaths. Locally, almost 5,000 deaths from COVID. And then worldwide, this is where we need to be and where we're going, is already 218 million doses of vaccine have been delivered. And this is the most important step as far as managing COVID and controlling death and controlling cases. In the US, approximately 6.5 million first doses have now been administered, which moving fast as we can to get everyone vaccinated. Next slide. So what's new? So there is, and these are, Kelsey, we really do go with the CDC guidelines and recommendations. We know that certain health departments and guidelines may vary depending on what state you're in. But what's new now is there's a shorter quarantine period. So as you remember, when COVID first came out, if you were exposed to someone who had COVID, you had to quarantine for 14 days. If you developed any signs and symptoms, that's when you would get tested. But assuming you made it through 14 days without any symptoms, then you were allowed to go back to work or come out of quarantine. So because of that, a lot of people were missing time from work, PTO. I know specifically several coworkers who have had to go through quarantine periods, not once, but twice, multiple times, because exposure is very easy. So the CDC has shortened the quarantine period so that more people would be honest about exposures and that we could probably, hopefully, try to catch things in a sooner fashion. So the new guidelines are that if you are exposed to someone with COVID and you do not have any symptoms, then you can go back to work, assuming you don't have any symptoms, and come out of quarantine at day 10. Now, there is one option where you can get out a little bit quicker, and that is after day 5 from the exposure date. If you get a COVID test and you remain asymptomatic until day 7, then you can get out early of COVID quarantine at day 7. So these are new guidelines. So it's a way that people who can get access to a test and have no symptoms can actually get back to work sooner at 7 days. Now, that test that you have after day 5 has to be a PCR test or an antigen test for it to be valid. And these new guidelines are not for people who work in a healthcare arena. And so if you work at a clinic or a hospital or a nursing home as a provider, these new guidelines do not apply to you. But for the general population, they do. And this is a way to get back to work quicker and get out of quarantine. The other thing is how long does protection from a previous infection? Well, the guidelines are that if you've had COVID, you're pretty much protected from getting COVID again for up to 90 days. Now, that does not mean that your test has gone away and has become negative. So some people's test can remain positive up to 90 days. But what we're talking about is being contagious. And so after you've had a COVID infection, you are presumed cannot get another infection with COVID for up to 90 days. So if you have an exposure, you should report it, but you can self-monitor and don't need to be out of work or out of any other activities. Asymptomatic testing seems to be the ticket to do stuff. So there's a lot more people getting tested. So they can get on a plane, maybe go to Hawaii, go to other states that you weren't able to travel, or international travel. Also is to visit someone in a healthcare setting. So to visit someone that's in a nursing home, a negative test. So we're doing a lot more asymptomatic testing so that you can show that you currently don't have infection. And assuming you don't have symptoms, you can have almost a pass or a ticket to be able to do things that you couldn't do in the past. Quarantine protections, as Dr. Mouzoon mentioned, that once you've been fully vaccinated, then if you have an exposure, you do not have to quarantine. And when we say that, it doesn't mean that you don't have to self-monitor. You still have to monitor yourself for development of symptoms, but you don't necessarily have to quarantine or isolate yourself at home. You can continue about your normal activities. You can go to work and do the things that you're supposed to do once you've been fully vaccinated. Good news is we feel like the third wave has now come and gone. We are at very low levels of COVID locally. And at Kelsey, our testing has really fallen off over the last couple of weeks, which is very good news. At the same time, vaccinating people, social distancing. And what we don't know is there going to be a fourth wave or a fifth wave. And so we should stay on guard, watching for that. Probably our biggest risk for a potential new wave is spring break. And so we'll be anxious to see what happens over spring break. The schools are now having spring breaks last for 2 weeks. So more opportunity for people to be mischievous and get into trouble. And so we do encourage that when you're traveling, still protect yourselves, your family. especially until you've been vaccinated from catching COVID. Monoclonal antibody infusion. So we finally do have an EUA approved outpatient treatment for COVID. And these are monoclonal antibodies. We do this here at Kelsey-Seybold. So if you are a patient who's at risk for severe disease, which is typically going to be older patients over the age of 65, or if you're younger than 65 and you have a significant medical condition or problem, then we can infuse you with monoclonal antibody. And what this does, and it has to be given within 10 days of the onset of infection, it reduces your risk of severe disease, in most cases now over 80%. And so this is the only approved outpatient, meaning you're not in a hospital, treatment for COVID. And we'll talk about some other myths of what people have tried to use to treat for COVID. But monoclonal antibody, if you're at high risk for severe disease, you should talk to your doctor whether you are a candidate, if you have COVID, for monoclonal antibody infusion. Grandparents. So the best thing about vaccination is that grandparents are going to get to see their kids and their grandkids. Again, we do want to make sure that they wait till they're fully vaccinated, which is 2 weeks after your second shot. Then we consider yourself fully vaccinated and that you can see your grandkids. If your grandkids or your children are not at risk for severe disease, then for example, they maybe have diabetes or something, you can visit them without a mask. If they do have risk for severe disease, then you should be protecting that person as well and continue to wear a mask. But this is now, there are CDC guidelines and recommendations about how grandparents can now visit with their grandchildren. And we think this is very important. And we've seen some emotional grandparents when they've gotten their vaccine, they're so excited that they can see their kids or go to a baseball game or a soccer game and watch kids. Give me 1 second, my lights went out here. You know, the latest technology of motion sensitive lights, but anyways, variants, Dr. Mouzoon talked about variants. We don't think that variants, you know, as a medical community is surprising, is expected. Viruses mutate all the time, is why we have to get an annual flu shot every year. That flu shot is looking at what are those variants, what are the changes. The coronavirus is just happening to be mutating at the same time we're dispersing vaccine. So we want to pay attention. There may be modifications for the vaccine. We don't know yet about, are you going to need to get revaccinated at 6 months? Is it an annual vaccine? But these variants, and this is one of the benefits of the messenger RNA vaccines, is they can be updated very quickly to contain these variants and protect us. And so more to come on that. But because of the variants, you may not be as protected from your vaccine as we first hoped, but it's still significant protection against severe illness and hospitalization, which is what we're all trying to prevent, is people in the hospitals, filling the ICUs, and definitely dying from COVID. And so vaccination is the key to that. And then a new term, which you may or may not heard, is what are called long haulers. Like any viral infection, and that's what COVID is, it's a viral infection. Sometimes patients or people get long-term symptoms. And so the best thing to think of as far as an example would be mononucleosis. So patients who've had mono, which is a viral infection, sometimes have fatigue for months and months, and sometimes over years, where they get body aches or arthritis and these kind of things. Very similar things happen with COVID. So this is not unexpected as well. But the COVID long haulers, typical symptoms are fatigue and headache, and maybe this fogginess of thought or processing. And that can unfortunately last for months. If you feel like you're in that category of potentially you've had symptoms remaining from COVID, you just don't feel right and months have passed, you need to talk to your physician about that. There are in academic institutions, their development of clinics that are seeing patients who are long haulers. So we can learn more about this. We can learn about potential treatments. So don't suffer in silence. You know, if you feel like you've had COVID symptoms and it just doesn't seem to be going away and it's lasting for a long time, talk to your doctor about that. Next slide. COVID myths. So all of these that are listed here at one point or another gave what I would call a signal, meaning there was a potential or a possibility that these were going to be helpful in the treatment for COVID. As everyone knows, the hydroxychloroquine became very political early on, but early on, that was the standard of care in China. So what we needed is evidence-based clinical studies. And so the evidence clinical-based studies have been done, and hydroxychloroquine does not improve or treat COVID. And if, in fact, we have now not seen hardly any requests for this anymore. I think most people feel comfortable with that. Vitamin C, vitamin D, and zinc, again, have given some signals that maybe they're helpful. Most people think, well, they're pretty safe. And in most cases, they are as far as prevention or helping to manage COVID. These studies are coming out as well. The vitamin C study, unfortunately, showed not to be helpful for COVID. This evidence and the verdict on vitamin D and zinc is still to be determined. And so those are kind of things you want to talk to your doctor about whether it's safe for you to do. The latest crave and phase is ivermectin. So ivermectin, probably most of you have not heard because it's used mostly in the veterinarian practices, possibly prevention of heartworms. In fact, if you went to a feed store, you'd probably see ivermectin over the counter. So ranchers and cattle people buy this for their livestock. It is sometimes used in humans for unusual infections. And can have side effects. So we're always very careful. The ivermectin data, again, gave a signal. And in fact, there was a large study done recently at the Cleveland Clinic that has shown this not to be helpful for COVID. And there's been actually FDA warnings and guidance against prescribing ivermectin. So please do not see this. Don't take this. Don't ask your doctor for it. It is not going to be helpful for you, and potentially can be harmful. Z-Paks and steroids. It seems like anyone who goes to an urgent care who's diagnosed with COVID leaves the urgent care with a Z-Pak and steroids. Z-Pak is an antibiotic. It does nothing for COVID. And steroids may have a role in COVID, but not early on and not late. It has to be timed at the right time. And this is usually done in the hospital with early infection when your oxygen levels might be low, and then steroids might be helpful. So you need to be very careful about taking steroids. It can, in any kind of infection, worsen the condition. And so it has to be really highly considered when is the right time to use steroids for the treatment of COVID. Next. COVID oddities. And so these are things that we heard about. You heard stories about early on with COVID, and it's like, this doesn't make any sense. You know, COVID or coronavirus, it's a cold virus, but loss of taste or smell. I will tell you, early on, we heard of this and no one believed it. Said, no, there's something weird going on. It's not COVID. We now know that if you have loss of taste or smell, along with a respiratory condition, I can tell you probably 99% likelihood you have COVID. I don't need a test to tell me that you have COVID. It is one of those very clear and unusual symptoms from COVID. Now, the thing about loss of taste or smell, this is how COVID affects your neurologic system. And so a lot of times it's associated with a headache. This kind of symptom can last for a while. So there in some studies, it may take over 3 months for resumption of normal taste and normal smell. and maybe even sometimes it doesn't get back to normal at all. So if you have loss or taste and smell, be very patient about that. It should come back. And as an employer, it is not a reason why not to come back to work. After 10 days or up, the contagiousness of COVID is gone. Regardless of the taste or smell symptom, they can come back to work and resume normal activity. COVID toes, everyone gets worried about COVID toes. It's where the toes are black and blue and looks like there's a blood clot in the toes. And this is just a skin finding. It is not that you're about to lose your toe or anything like that, but it does worry a doctor. It worries anybody who sees this. Again, unusual, but if you have it, you have COVID regardless. And so if you see a strange discoloration of your toes associated with a respiratory problem, you probably have COVID. Melanie talked about blood clots. Blood clots, for whatever reason, during the COVID infection period, people's blood becomes a little bit more thick or hyperactive and can lead to clots. And that period of increased ability to make clots, whether it be in your legs or in your arms or in your chest, can last up to 90 days. So in certain cases, patients with COVID, if after you have a discussion with your doctor, sometimes we use blood thinners for up to 3 months, protect yourself from blood clots. Could be baby aspirin or even things that are even stronger blood clots. That's a conversation between you and your doctor, whether you're at risk for blood clots and you need to take any blood thinners for a short period of time. Diarrhea, early on, we thought we're safe. It's not anything to worry about, but it turns out that 15 to 20% of patients with COVID, this is their only symptom, diarrhea. So a gastrointestinal condition that lasts more than 2 to 3 days, you have to be worried about COVID. You have to think about COVID, and you should get tested for COVID and talk to your doctor about that. And then heart and kidney problems. So COVID affects a specific receptor in your nose. That's how it enters your body. Well, those receptors are also in your intestines. That's why you get diarrhea. It's also in your heart. And so some people develop heart problems after COVID. It's also in your kidneys. So a sudden loss of kidney function or kidney injury can be a sign or a side effect of COVID. These are usually occur in the more moderate to severe infections in patients we see in the hospital. But if you have COVID and you're concerned about these things, then talk about your doctor whether you need to be tested, especially if you participate in sports before going back to any kind of a physical activity that's strenuous. You want to make sure that that's okay to do after you've had COVID. Next. Mitigation. So mitigation, big word, is how to prevent COVID. Masking, still very important. Social distancing is very interesting. A study just came out in the children that possibly we can go from 6 feet to 3 feet. The CDC is still looking at that for school-age kids. Hand washing, we're taught this as kids. Wash your hands, wash your hands, wash your hands. It's the best way to prevent giving someone else a condition or infection. Virtual meetings like we're doing now, we know that more and more people are starting to go back to work, have regular meetings. And as Dr. Mouzoon mentioned, having meetings in person, if everyone has been vaccinated in the room, fully vaccinated, probably okay not to have your mask. If not, everyone needs to wear their mask and still wear it and be 6 feet apart. Plexiglass. The data is still not clear whether that helps. It sure makes us feel better that there's plexiglass between me and the person sitting next to me at the restaurant. But I think this is something we'll see as more restaurants open, more places to go, movie houses, theaters, as a way to safely separate ourselves from others until we've been vaccinated. Door screeners, we still do door screening. For anyone who comes to Kelsey who visits, you'll get your temperature checked. You'll be asked about symptoms. Testing is a great mitigation. If you are sick, don't go to work. That's how you get mitigated, and then get tested so you know whether you have COVID. And then vaccines is the most important mitigation strategy we have, as we need to get more and more people mitigated. And then virtual health. And so I will tell you at Kelsey-Seybold Clinic, before COVID, start since 2016 to 2020, we did a total of 5,000 video visits. 2020 alone, we did 250,000 video visits. It is a great way to keep yourself safe, keep everyone else safe, and still get the medical care that you need. Next slide. And then what I'd like to talk about is how virtual health still should remain an important part of our care. So when we talk about social distancing, we're not implying medical distancing. So getting treatments for your chronic conditions, blood pressure, diabetes, getting your wellness checks, preventive colonoscopies, mammograms, all still very important. We know that early on in COVID, people were scared to go to the doctor. They did not get their checkups. We couldn't get our colonoscopies. Now is the time to get caught up. What we don't want to see is delayed diagnosis of cancer, delayed diagnosis of diabetes. People end up in the hospital as a first side effect of blood pressure, it's stroke or heart attack. So seeing the doctor is still very important. You can do that through virtual health. We can do any condition you can think of, with only a few exceptions, through virtual health. So talk to your doctor about getting your routine maintenance, getting your care for your diabetes, your high blood pressure, getting your checkups through virtual health, and a way we can continue to get healthcare in a very safe way. But also remember, COVID is not the only medical illness. There are so many other medical illnesses we have to think about and worry, and that we need to protect our hearts. We need to make sure our blood pressure is doing good. We need to stay in good physical health. We need to eat right. Mental health, management of depression, anxiety, stress, all these things we can do through virtual health. And so we want you to connect with your doctors and your healthcare providers to make sure we stay well. Next. Now that I'm vaccinated, I think this is where we come to the question and answer session. And we'll turn that over to Elaine, and we'll open up for some questions.
Hi, everyone. All right, let's see. We had some questions that came in. Let's start with variants. What do the ramifications of the new COVID-19 variants have on the existing vaccines from Pfizer, Moderna, and Johnson and Johnson? Do we know if we'll have to get a third dose for covering any of the new variants, such as the South African variant or the Brazilian variant?
Melanie?
So we don't really know the answer to that question yet. Were you going to talk, Donnie? I'm sorry.
Oh, go ahead. Go ahead.
Okay. I tell people it's kind of like having a lock and key. So the vaccines are giving you the ability to like hone in on this spike protein, but now the spike protein has changed a little bit. And so actually it has changed to fit the receptors that Dr. Aga was talking about, the receptors on your heart and kidney and in your nose. It's changed to fit those receptors better. And that's why it's more contagious, why it takes fewer germs to actually infect you. And so it's more virulent. And so fortunately for the vaccines, the antibodies we produce to recognize that spike protein still fit pretty well. But it's a little bit like having a little looseness in that key and having to jiggle it a little bit. So, so far it fits well enough that the vaccines are still very effective. The Johnson & Johnson or Janssen vaccine was very, very effective in Brazil, in South Africa, as well as in the US. It wasn't as effective in preventing mild or asymptomatic illness, but for severe illness and death, it was very effective. So that is likely the same case with the Moderna and Pfizer vaccines, that they are a little less effective than they were originally touted. There have already been, reports of that in the medical literature because of these variants. But so far, none of the variants have escaped our vaccine tactic. And so really vaccination as Dr. August said, is the most effective thing. And all of the current vaccines can easily be updated to change with the protein with that spike protein change if necessary. So I think vaccination is our way out, and we don't really know when we might need another booster. My guess is because it doesn't mutate quite as fast as the flu vaccine. We hear a lot of talk about different variants, but the flu virus really mutates more rapidly than the coronavirus. And so my guess is it'll probably be every couple of years to maybe every 5 years. I don't see this virus completely leaving our society. I don't think the human race will ever be free of it. But I think that it will be very controllable with vaccination on a routine basis. But how often will it be? Every 10 years like a tetanus booster, or every year like the flu vaccine? We really don't know.
So if I can just make a quick comment, those are all excellent points. And one is, if on a yearly basis, we recommend the flu vaccine. On a best scenario, flu vaccine only protects us about 60% of the time, and what the benefit of it is preventing severe influenza and being hospitalized. And so if you do get flu after a flu shot, it's typically mild. And the same way to think about coronavirus as well, that even though there are variants and maybe it's not 100%, it is 100% protection against severe disease and hospitalization, which is the most important thing. And our goal as a medical community is to make coronavirus like all the other coronaviruses, and that's just a cold virus. Nobody's scared of the cold or the common cold. We did every year. What's different is that this is so new to our bodies, this virus, never seen, it's highly reactive that it leads to death. And so over time, hopefully we have greater sensitivity, greater immunity, and we can just damp it down to a mild cold. Lane, you're on mute.
Thank you. We have some questions that came in about mitigation efforts and returning back to work. The first part of this question is based on remote work. So currently, part of the office is working remotely, and they are alternating times that employees are in the office. The question is, once they return to work full-time, would it be a good idea to have every employee have a negative COVID test before they return to the office altogether full-time?
So that's a very good question. And I think that's going to be company by company, because COVID testing, and to some degree can add expense. We have done a lot with COVID testing of our own employees, especially in areas where patients are more vulnerable, like in our cancer center and in our surgery centers. And so coming back to work and having COVID testing is a mitigation technique that some companies are doing. And so there's nothing wrong with that. But you can also, do other things to mitigate that. And if you don't feel well, don't come to work, get tested on your own, continue to wear a mask, and encourage your employees to get vaccinated, because that is really the key long-term is a vaccination and not testing over and over and over and over again.
So the second part of that question is employees who tested positive and and would be considered long haulers. If they are still showing symptoms of COVID, do you have any guidance on how to handle that situation?
Yeah, so it's a good question. And so we use 2 dates of when someone's no longer considered contagious. And that's what's the most important thing. One is if you are not hospitalized, then that's 10 days. So after day 10, even though you still may have symptoms, as long as you don't have fever, you're no longer considered contagious. If you were hospitalized, so that's a more severe illness. So those patients had more virus in their body. So it takes a little longer to not be contagious, we usually use 3 weeks or 21 days. Then you go back. So as a long hauler, typically you don't continue to have fever. So fever has to be gone, and that would be I mean, I have not seen a long hauler who continues to have fever, but you may have the other things such as fatigue, headache, or this, this kind of brain fog is what people call it. It just don't feel right. Those are not things that should keep you out of work, but it is something you should talk to your doctor, because it might be of benefit to be referred to a specialty area center, such as here Houston, be Baylor or UT Houston probably are developing COVID haulers clinics.
And I would also say there is some little bit of evidence that vaccines in people who are long haulers may actually be beneficial, not only at preventing illness, but there's some suggestion that it can help with their symptoms, although that's really needing a lot of further study to be confirmed. So it's not a reason to not get vaccinated if you're a long hauler.
Yep.
So we have 5 minutes left. So I have one more question for Dr. Aga, then we're going to hop on over to 2 questions for Dr. Mouzoon quickly. Dr. Aga, this question is about mitigation efforts. So after employees are vaccinated, at what point can you start decreasing mitigation efforts in your office?
So I guess we're assuming that everyone is vaccinated in the office. And so once everyone, and this is the new CDC guidance for indoor activities, and it's very easy to find on the CDC website. And I would encourage you, if you haven't, go to the CDC website, because there's a lot of information about how do you do events, how do you have long, big meetings, how you do this and that. There's a lot of information for employers on how to mitigate. And so the goal is after 2 weeks, you've been fully vaccinated. As long as everybody's been fully vaccinated, then you can meet without a mask. It does not mean that you shouldn't be doing hand washing. It doesn't mean that you shouldn't be doing other kind of mitigation type things, but just to stay safe. And because, again, and for what period of time is this? It's 90 days. So your vaccination kind of period of fully covered right now is all we know is 90 days. So after that, it's back to mitigation until the CDC has more data. Our guess is that they will continue to extend that. But right now, I think you should really look at the CDC guidance and follow that to the letter, because they're always going to include the latest data and information about keeping us safe, not only at home, but at work.
Wonderful. Thank you so much, Dr. August. We're going to hop over to Dr. Mouzoon. Dr. Mouzoon, we have some questions about side effects from the vaccine. If employees are experiencing side effects from the vaccine, should they be at home or quarantined during that time, or is it okay to allow them to work during the time they're experiencing side effects?
Well, that's a great question, and it will come up because there will be people with low-grade fever or some chills. And, if people are feeling bad enough that they had to take some ibuprofen and go back to bed, clearly they shouldn't be at work because they're not feeling well anyway. But most people, it's going to be a mild symptom, and the ibuprofen or whatever will help them, and then they don't need to go back to bed. Our decision at Kelsey-Seybold was, if they just got the vaccine and they're having these expected side effects, that they're okay to work. They will be masked. If the side effects last longer than 2 days, that's a real concern, and testing should be considered.
And let me add to that, Melanie, is that we have seen after the first shot, patients get COVID. So side effects more than 2 days, you should get tested for COVID, because the vaccine has not taken effect yet.
So the last question we'll have for today for Dr. Mouzoon is also about the vaccine. Do you foresee there being a combo flu shot and COVID vaccine that people will take seasonally?
Well, that's actually a good idea, because we do want people to take seasonal flu vaccine. So if the COVID vaccine becomes an annual affair, I suppose it's possible that people will combine it with the flu vaccine, but that would probably be 8 years down the road that we have something like that. I wouldn't expect it right away because the way that the vaccines need to be stored and handled, there may be issues with mixing the two. So for example, the Pfizer and Moderna are in this little lipid coating, or a little fat bubble is how the mRNA is protected. And it probably would not be, well, it wouldn't be soluble with the flu vaccine. And so they'd have to do more research and development to make a combination vaccine.
Perfect. Well, thank you so much. We're going to wrap up our time today with Dr. Aga and Dr. Mouzoon. I know they have to get back to seeing patients. So big thank you to all of you who tuned in this afternoon. We appreciate you spending your lunch break with us. This presentation was recorded, so a copy of it will be emailed out to you. Again, if you have any questions about Kelsey Care, please feel free to reach out to the Kelsey Care team. And if you need more information about COVID-19, we have an extensive COVID-19 FAQ section on Kelsey-Seybold's website at kelsey-seybold.com. And we hope that all of you have a wonderful afternoon, and we look forward to seeing you at next month's Business Health Connect. All right. Bye, everyone. Thank you, Dr. Mouzoon. Thank you, Dr. Aga.
Thank you.